Good morning. I'm really, thanks so much. Harold's done a great lead-in, and what I'm going to do is give you some of the trials and tribulations from people on the ground. So I wanted to show you a picture of what quality looks like, how we measure it, and what we've learned over the past 10 or 15 years. I work for NCQA, the National Committee for Quality Assurance. We're a not-for-profit. We accredit health plans, and our accreditation is performance-based, so about half the score is based on how they perform on measures like whether children who are prescribed an ADHD medication receive appropriate follow-up care. And so this measure has been in our measure set since at least 2006. And it's not very impressive performance, huh? So only about 40% of the kids, this is kids who are on the medication for at least, I think, 9 months. We're looking for 3 visits during a 9-month period. And the idea is we're using kids who are on an ADHD medication because ADHD diagnoses often are not present when the medication is used, and those ADHD medications are pretty specific to the condition. I think I skipped, I thought I had a slide. Oh, I do. This is the other one that just kills me. People who are sick enough to be hospitalized for a mental illness. This measure is looking at how many got an outpatient visit with a psychiatric, a mental health practitioner within 30 days after discharge. And you have to be pretty sick to be hospitalized for a mental illness. This is what you see are the differences. I think the red is commercial or private health plans. The Medicaid plans are in, I guess, green. I can't really tell the colors, but you get the picture. It's not really that good, and it hasn't changed. So I think these are accountability measures where we score health plans on it. The measures are in the Medicare STARS program for Medicare Advantage plans. So having a quality measure, having accountability, doesn't necessarily focus attention on improvement. And in behavioral health measures, we have most of our behavioral health measures show this kind of pattern of either not much improvement, and even in these measures, we're seeing this a tendency to decline, right? And so that's extremely worrisome. So I just want to put out the idea that just because you have a quality measure doesn't mean that it's going to galvanize the kind of attention, even when there's some accountability attached to it. And some of this might be related to different ways that care is organized, and the cultural collaboration of the general medical and the behavioral health sectors, and how health plans can work on that. So using quality measures and getting the improvements that we hope to get, that the quality strategies say we're looking for: improved population health, reduced cost of care, improved care experiences, and quality of care. That's where we're headed. What are the measures that we have today? We did a review of behavioral health quality measures that exist for a project that we did for the federal government. We found that not very many of them are nationally endorsed. There aren't very many nationally endorsed measures, and few address children's needs. And it's pretty hard to see in this slide deck. I did point out tried to point out the ones that address children's conditions. So the ADHD measure and the follow-up measure I just mentioned. There's also measures looking at depressive disorder, suicide risk assessment, maternal depression screening. These are measures that are currently being used in things like the Meaningful Use Program for providers, Medicare Advantage reporting, and the Children's Core Set, the children that states voluntarily report for children in the in Medicaid and CHIP programs. So mostly process measures, mostly focused on data that you can capture from claims data, because that's the easiest way to get information, really hard to get to medical records. So Harold talked a little bit about what makes a good quality measure. These are the criteria that are used by the National Quality Forum and that we've used as we've developed measures. I really wanted to point out this important section of trying to understand how common is a problem, how much disability does it cause, how expensive is a problem, is part of that importance. The other part of it is how good is the evidence base. When we defend the measures, like that follow-up after ADHD measure, I just had the opportunity to defend that measure in front of the National Quality Forum, and there were a lot of targets, a lot of questions about whether that's an evidence-based measure. Who decides how many visits you should have within 9 months of getting a prescription? The guidelines don't really tell us that. We have expert groups that kind of help us to do that, to say, well, that sounds pretty good. Other people said, well, do you count telemedicine visits? Would a phone call be sufficient? Does it have to be face-to-face? What's happening during that visit? In fact, I'm part of a contract where we're actually developing a measure for kids with ADHD that's looking to see, are their symptoms improving? And so, which in my mind would be a much better way to see whether we're actually doing well by those kids that are on an ADHD medication, but not so simple. So the other issue is this idea of scientific soundness of the measure. So Rachel's point about reliability and validity being specific to the use of the measure for the particular purpose. This is something that in our work has not actually, it's very hard to demonstrate, and we're working very hard to figure out better ways to illustrate that. Now, how do we get to a quality measure? What are the steps in development? We always start from the evidence. The best measures, like Harold said, those measures for diabetes, those are really the cream of the crop in quality measures in healthcare, because the guidelines have been very consistent across primary care and specialty societies, and the evidence base is strong, although it can change. So we always start from that and then try to prioritize concepts that make sense. And then we go through a pretty rigorous process of trying to develop specifications that ensure that we can make apples-to-apples comparisons across the different entities that we're measuring. So one of the things about claims data is that we can look at claims, and a code for a laboratory test is actually really pretty clear. You know, you can pull that out and you have a lot of confidence about that. We have less confidence. One of the reasons why those follow-up after ADHD and follow-up after hospitalization measures create problems is because we specify the kind of visit, and we might be missing ways that those connections happen that aren't captured in claims. We test it, we do public comment, and then hopefully through this whole process we work to get a lot of stakeholder feedback from the people that are going to be measured, the people who are going to use the measures, to make sure that we're working on the important topics. I want to walk you through a little bit of work that we've been trying to do to improve our measure set for children and adolescents. We have a Center of Excellence in Pediatric Quality Measurement. Kim Hugwood is part of our group. And we've been looking at how we could improve measures for adolescent depression. And the first step we did was to try to articulate, well, what would high quality care for adolescent depression look like? It'd be identified through, we'd have a screening process. There'd be a good assessment to really determine what the diagnosis is. Depending on the severity of illness, you might go into different paths of brief supportive counseling versus initiating treatment, which could be different kinds of treatment. And then there'd be measurement, assessment of symptoms and functioning, ideally over time. And we worked with an expert panel that helped us to focus our attention on what measures we thought would be most important. And for these children or adolescents with depression, who've been diagnosed with depression, our group said, let's focus on whether they're being followed and monitored adequately and whether they're getting to remission or to response. And so we actually built some measures that are based on some existing adult measures that are currently being used in some of those federal programs. One that looks to see whether kids are being, with a depression, are being monitored. And then two that are looking to see whether kids with depression are actually responding. Are their symptoms getting better? And for these measures, we're using the PHQ, either the PHQ-9 or the PHQ-A. So the hardest part of this work was finding places that already have a workflow for using the PHQ and that are following it. So we talked to a number of different organizations who said, oh yeah, we use the PHQ. Well, some use it for screening, some use it, and they might have a few cases where they use it, but it's not really institutionalized. And so we thought we had 3 places that had really institutionalized the use of the PHQ. So, so this kind of is the answer. So we actually focused on it. You know, our N is actually, this is the N of kids that are eligible for these measures. So adolescents who start off with a PHQ greater than 9, that have a depression diagnosis, major depression or dysthymia. And we look to see, did they get follow-up between 4 and 8 months from that baseline? Could we see where their symptoms were? Was there a symptom score? 83% had no PHQ documented in their record. Okay. Among those that did have it, you can see, I guess about half of them either remitted or responded. And these data are actually not that much different from data that are published on the Minnesota Community Measurement website, where they find it's the same kind of problem about, I think they have about a 20% response rate at 12 months, and most of the people that don't respond actually don't have any kind of follow-up documented. And the reason, so the typical way that we do in quality measurement, if you don't have the test, if you don't have the assessment, then you're considered a failure. And we know that a lot of those folks may have gotten better. In fact, they might not have come back to the office, and that's why there's not a subsequent score. But the way our quality measure says is you've actually got to go out and find those kids and make sure they're okay. These measures specifications are actually out for public comment on our website right now, and I might work with Morgan to make sure that we send you that website so you can see the details of what we're proposing. But what this really tells us is, when we're developing a quality measure and we're trying to get to outcomes, we've got to actually start back from the structure. We need to think about, is there an infrastructure for collection of these patient-reported symptoms? And in fact, is there an infrastructure for treatment? All of the settings that we're testing at are places that have integrated mental health services or mental health services available. Do they have evidence-based therapy? We're not really sure. We want to make sure there's access to treatment. Do they receive treatment? Most of the kids in our study are getting some kind of treatment. And then can we get to an outcome? Now, we've been really interested in thinking about how one could measure receipt of evidence-based therapy. And this gets to be a huge challenge in thinking about which therapies, what are the target populations, because we'd have to get to a quality measure, we'd have to say, kids with ADHD, did they get a particular evidence-based therapy that we can say that it was the same thing that was in Dr. A or Dr. B or Health Plan A or Health Plan B. We have to be able to determine whether that really does meet the criteria. And it has to be based on the evidence. And the issues about the data sources and access to confidential records is huge. We've just done some field testing where we had behavioral health providers say HIPAA, they can't share the data, they've got to get permission. Well, they can share the data with a health plan that's doing quality improvement, but they don't believe they can. And so that's a huge challenge. The work that I showed you about depression is really following a model for building to outcome measures that is being used in other federal work to develop outcome measures for adults, both in the general medical sector and in behavioral health, where there's an idea of trying to use standardized outcome measures, collect the data, use those measures for goal setting, and look for improvement across a population. Of course, we run into the problems that Harold mentioned about we have to decide what tools we're going to use, and they're not always tools available. We have to figure out where we're going to get the data, who's going to collect it. How much improvement do we expect? So for depression, this idea that you would get to remission within 6 months or 12 months, that's pretty well accepted, and that has become a quality, that's how that quality measure is set up. We're doing one on ADHD outcome. How much improvement do you expect in an ADHD in the Vanderbilt over 3 months, 6 months, a year? And what would be, and so for every measure, we'd have to think about what do you expect? And then who is accountable? Is it the individual clinician? Is it the practice? Is it the delivery system? Is it the health plan? So all of these are issues that we have to deal with if we're going to create quality measures used for accountability and respond to the needs that are in the Affordable Care Act. So just in summary, existing quality measures show limited improvement. The measures, we don't have measures that get at psychosocial interventions, and we're really struggling with these new outcome measures that we're trying to develop because it's just not part of current practice. And we're going to have to work together on demonstrating what are going to be the ways to make this useful for clinicians, relevant to patients and families and adolescents, and then also things that we can hold our system accountable for. Thank you.